Before I go into the theme, before I go into this talk, I would like to talk about the personal reasons why I was interested first in psychedelics and specifically ketamine. There are three specific reasons. The first one is that the most personal reason is that I myself was a candidate for the action of ketamine for suffering from treatment-resistant bipolar depression. The second reason was that I was at the perfect time into beginning to research psychedelics. I think we all are. This is a perfect time to begin to regain interest in the theme of antidepressant properties, anti-addictive properties of psychedelics. And the third reason was that I was born and I work in a country that is proud in being endemic to some of these substances, some of these plants, which are basically psilocybin from mushrooms and mescaline from peyote. I would like to disclose that this probably reflects how young I am, or reflects a little bit of my beliefs, but I have nothing to disclose regarding pharmaceutical slavery. I would like to go first on the background of depression. Most of you are familiar with it. We know that it's not just sadness, it's a group of symptoms that reflect that how it affects our body just as it affects our mood. This is one of the campaigns that was released in 2012 by the World Health Organization, in which it compares depression to a black dog that's very annoying, in which case I would think that it would be better to compare it to a cat rather than a dog, right? So what's the problem with depression? This is the largest trial of depression that has been released up to date. One of the things that we've learned through this trial is that up to 1/3 of the patients will not achieve remission, which is one of the objectives that we search for now, after even 4 steps of treatment, in which case we talk about treatment-resistant depression, the topic that I will focus throughout the talk. So when we understand depression as a group of symptoms, a group of affections, we need to understand that it's not just, it doesn't have a clear cause. It has a group of causes that altogether will give us our construct of depression. I'll try to go very briefly through each one of these. So the most known theory about depression, which you might be familiar with, is the monoamine hypothesis of depression. So basically what it says is that people with depression have a less concentration of monoamines in the CSF and throughout the brain. But what's wrong with this theory? First of all, antidepressants are long-acting, which means that they take about 3 to 4 weeks to begin to work as antidepressants. Why do they take so long? When during the first 24 hours, they elevate the monoamines in patients. The second thing that's wrong with this hypothesis is that experimental depletion in animal models does not necessarily cause major depressive disorder. Also, in vivo studies have shown that MDD patients show similar levels of monoamines than controls. And the last thing is that up to 1/3 of the patients will not respond to conventional antidepressants, which basically all work in the monoamine system. We know now that genetics form an important part of depression, maybe not as important as bipolar disorder, schizophrenia, but up to 30% of the disease may be explained by genetics, which leaves 63% of the disease not explained by genetics. So it will be explained by all of these other causes. We also know that the HPA axis has been shown to be affected in patients with depression, specifically that there's a less negative feedback as they're supposed to be, which means that chronic stress will cause a high stress signal. And this is proved by that MDD patients have shown to have higher levels of cortisol, higher levels of corticotropin, and higher levels of cortisol. This has shown also that there is an adrenal and pituitary hypertrophy, and there is a classic test that we used to do in which we give exogenous cortisol to the patients, and they fail to suppress their endogenous production. This leads to inflammation. So if we understand MDD as a maladaptive response to chronic stress, we can understand it also as an inflammatory disorder. There are a lot of things that might add to this theory. Cytokine-induced depressive symptoms, that higher levels of inflammatory markers are shown to be correlated with some activity in areas that are involved in MDD, that patients that receive interferon treatments, such as renal cancer patients, will sometimes develop depressive symptoms, that chronic disease such as multiple sclerosis, such as lupus, will have depressive symptoms. Higher levels of interleukins will be found in MDD patients, and some other proofs that it is an inflammatory process as well. When it comes to neurotrophic factors, this is a key aspect in which I'll try to talk a little bit more later when we go into the ways that we think novel-acting antidepressants work. How does this explain some of the questions that we earlier touched on the monoamine hypothesis? We think now that delayed antidepressant efficacy responds to the fact that BDNF increased synthesis induced by antidepressants is the delayed response. And this is also proved that depressed animals have been found to have less messenger RNA BDNF. That exogenous administration of this neurotrophic factor reverses changes found in MDD, and that there are some genetic variants that induce and are associated with suicidal ideation. So what happens when we have a normal BDNF genetics is that we found normal dendritic density and normal connections between neurons. What happens when we have an abnormal genetic variant of BDNF is that the spinal density dramatically decreases. And this has been associated with depressive symptoms as well as depressive animal models. What do antidepressants, conventional antidepressants, do so then? So they increase the monoamine levels in the synaptic space. This is true for all of them. But what makes them work later? What makes them work up to 3 and 4 weeks later after administration? It's the fact that they induce more expression of BDNF and more release of BDNF, which is the neurotrophic factor that we just discussed. I won't talk a lot about some more recent hypotheses of depression. I want to go first into function of structure. This is a very simplistic way in knowing how some of the key regions work. The red marked regions are some hyperactive regions in MDD, while blue regions are hypoactive in MDD. This has led to some of the most recent, well, not very recent, but some of the treatments that we now use in treatment-resistant depression, which is basically transcranial magnetic stimulation and deep brain stimulation. So what we do with deep brain stimulation is that we either stimulate or inhibit some of the regions that are associated with depression, specifically the nucleus accumbens and other regions. So finally, I'm going to go into the glutamatergic hypothesis of depression, which is one of the targets for novel-acting antidepressants, specifically ketamine, specifically also psilocybin. What we know about glutamate in depression is that when we have an inadequate response to stress, neurotransmission that is mediated by glutamate and GABA is altered. This might lead to excitotoxic properties that induce dendritic atrophy that we discussed earlier, and may induce changes specifically in the hippocampus and the prefrontal cortex seen in depressed patients. Also, we know the chronic antidepressant properties may revert these changes and may also prevent stress effects in the system. So recently, the interest has turned into the glutamate systems. There are some imaging techniques, specifically spectroscopy, that allows us to see how much neurotransmitters are found in specific regions related to depression. So basically, in depression and in bipolar disorder, there is an imbalance in excitatory and inhibitory metabolism, which is mediated by glutamate, basically. So typical monoamine antidepressants work later because they only induce major expression of BDNF. This takes a while, this takes a few weeks, and so we have antidepressant properties that are later acting. When we talk about novel acting antidepressants, which are rapid, which have a robust results, rapid and efficacious, is that not only do they induce BDNF expression, but they also induce a rapid release of BDNF already stored in vesicles, which is basically the reason in which they have a rapid effect and later have a long-lasting effect. So now I will go into how we think they work. Specifically, I will try to focus on ketamine, which has a lot more evidence right now on how it works, a lot more evidence clinically, and a lot more evidence in animal models. What are psychedelics? Most of you are familiar with the definition of psychedelics, which was born in a letter by Humphrey Osmond, a psychiatrist, to the writer Aldous Huxley. Basically, what he said by defining these substances is that they manifest or make the mind or soul visible. So what are psychedelics? When we talk about regular psychedelics, we talk about the combination of some plants, which is found in ayahuasca. We talk about DMT, we talk about LSD, we talk about mescaline found in peyote, and we talk about psilocybin. These all work in serotonin receptors. But we can also talk about atypical psychedelics, specifically some psychedelics that work in another neurotransmitter system, basically glutamate. So we can talk about ketamine, PCP, salvia, and dextromethorphan, which have been found to have antidepressant properties as well. We all know that after the Controlled Substances Act in the USA, the psychedelic research has dramatically fallen. So beforehand, in the 1960s, there was, these are the proportion of PubMed publications that include the word psychedelics before and after the Controlled Substances Act. It's just rising nowadays, slowly, but effectively. So now I will go into two different substances. Ketamine as a synthetic cousin of regular psychedelics, and psilocybin. I will try to show you the first study, the first modern study that showed the ketamine's antidepressant properties by Dr. John Crystal, and one of the latest and most modern clinical studies by Dr. Carhart Harris and Dr. David Nutt showing the antidepressant properties of psilocybin. What have we learned through this first ketamine study is that when administered to depressed patients, specifically treatment-resistant depressed patients, ketamine has an action in the first hours. It shows a difference with placebo during the first hours, and this response lasts up to 1 to 2 weeks after administration, even when people are washed out from typical antidepressants or from typical mood stabilizers. So this is why, after the first publication in the year 2000, publications have grown dramatically involving ketamine. What happens when we compared regular MDD patients to bipolar patients is that it reaches a peak during the first day, but it also lasts up to 7 days. So now we know it works pretty effectively. It has a robust response, and this response may last up to 7 days to 1 week. So how do they work? What differs from typical or conventional antidepressants is the fact that when we act in the NMDA receptor for glutamate in a GABA interneuron, this induces or inhibits the action of glutamate release. And also, when we block the same receptor in a postsynaptic neuron, we allow glutamate bursts to act through AMPA receptors. AMPA receptors not only induce a major expression in BDNF, but they also induce rapid release of the glutamate stored in vesicles that I was talking about earlier. So this leads to a rapid action, this leads to a robust action, and this leads to a long-acting action of antidepressants. What do we know about its mechanism of action? We basically don't know anything. We know that it may act as an antagonist in MDMA, as it was released first as an anesthetic, but this doesn't really explain its antidepressant properties. Why? Because other antagonists, such as memantine, such as riluzole, do not really have these properties. It seems to work also to do some monoamine neurotransmission through opioid neurotransmission. It has an indirect action through AMPA receptors. It has some inhibition of some of the enzymes that are related to the expression of BDNF. The BDNF released some inhibition of the lateral habenula that was just released in a Nature paper, and also the subjective experience of people when given a dissociative anesthetic such as ketamine. What has been our experience in the National Institute of Neurology? I realized basically that I didn't have anything to teach the international community because I started later interested in beginning the trials. However, since we know that ketamine works, we may not know how often we can give ketamine. There is a misuse potential, there's an addictive potential when using chronically ketamine, and specifically in a larger dose. So what should we do with ketamine? Is there a clinical response when used as an augmentation strategy? This means that patients may be on a stable dose of antidepressants or mood stabilizers, and they might not achieve response, but they might maintain ketamine's response as an augmentation strategy. So should treatment as usual be continued when given ketamine? These were two of the major questions that we tried to respond. So we included patients, treatment-resistant patients with bipolar depression or unipolar depression, and we kept them on a stable dose of antidepressants and mood stabilizers. This dose and this treatment did not achieve response beforehand, but we'll see if they maintain response. This is the first publication that we had with 11 patients in which we replicated that during the first hours, we can find the response as shown in other clinical trials. But what we showed, or what we learned, is that when we use treatment as usual beforehand, when we kept them on treatment as usual, this response that usually faded within the first 2 weeks was maintained up to 4 weeks, and in 3 patients was maintained up to 6 months. So we later expanded it to bipolar patients, which meant we also replicated the findings that during the first 24 hours, some of the depressive scale severity lowered dramatically. But we also found that this response was kept up to 4 weeks after treatment. When we look at the means of this course, when we look at, yes. I think you may save your question for after the talk is over. We found that unipolar depressed patients had a similar response as bipolar depressed patients. When we increased the sample up to 22 patients in total, this response was also kept for 4 weeks, and some of the patients in both groups kept it up to 6 months. They had a similar response rate throughout the 4 weeks, and bipolar patients did actually better than unipolar patients. When we tried to correlate if there was a specific medication that kept this response throughout the month and the 6 months follow-up, we didn't find a correlation, but that's probably because we had a very diverse antidepressant treatments. But there is preclinical evidence that lithium might work as a mood stabilizer that prolongs this response. So what we observed a similar clinical response in remission rates. We found a similar response in both groups of patients, but we found longer times until relapse with different antidepressants and mood stabilizers. Now, introducing one of our latest friends, psilocybin, I want to make a comparison between the two psychedelics. I've focused firstly on ketamine, but now we have a psilocybin trial that just started, and we're trying to run a trial on mescaline or peyote. This is one of the latest studies that found that with a high dose of psilocybin guided by psychotherapy, not only did you have an effect during the first 24 hours, but this effect would be prolonged up to 3 months in a 3-month follow-up. So when we use some scales that measure depression severity, we find within the first week a dramatic lowering of the severity, which is sustained up to 3 months. This is a major discovery, this is a major finding, because patients receive only 1 dose of psychedelic and they can maintain this response. What is another benefit of using classical psychedelics is that we haven't found addictive properties with regular psychedelics. So how are they alike and how are they different? You might be familiar with the Altered States of Consciousness study, which was developed in the 1960s, which show some of the effects that these substances have. When we talk about ketamine, we found a lot more effects on vivid imagery, synesthesia, visual alterations, and dissociative effects such as disembodiment. When we compare it to psilocybin, we found a similar profile, which makes them similar. So that's why I like to call ketamine a synthetic cousin of regular psychedelics. Compared, they might have some difference, but basically they have the same profile. This is one of the similarities between both psychedelics. How do they work? They work basically through the expression of BDNF, a similar effect that we talked about earlier with typical antidepressants. How does ketamine work? We talked about the NMA blockade, the glutamate increase that works in AMPA receptors, and so induces a BDNF increased expression and release. How do psychedelics work? This includes all regular psychedelics, all traditional psychedelics found in mushrooms, found in LSD, found in DMT, found in ayahuasca, and all that I talked earlier. They have an indirect effect on glutamate. The 5-HT2A receptor is a receptor that modulates glutamate release. So when we agonize, or when we act as a stimulator in this receptor, we produce the same glutamate increase as found within ketamine. This allows an AMPA agonism, or an AMPA action, that finally converges in the release of BDNF. Not only this, but we do in vivo studies in the activity in the brain. We found that ketamine and psilocybin work in the same areas, basically, that are shown to revert the changes in MDD. When we work in the limbic structures through regular psychedelics, we found that it reverses the changes. It reverses the hyperactivity of the amygdala and some other structures, which will augment resilience to stress and finally lower depression and increase well-being. And when it acts in the cortex, specifically in the prefrontal cortex, an entropy effect has been found, which decreases rigid thinking, some of the things that we do with regular psychotherapy, and finally, less depression and more well-being. It also acts through an inverse post-traumatic effect. So this might also explain why it lasts so long. When we do an in vivo activity using LSD not in patients but in controls, basically what we find is regions that have been related to the default mode network, which is the network that is present when we basically do nothing, think about nothing. It diminishes its connectivity and therefore induces profound changes in consciousness and ego dissolution, as we found earlier when studying some of the altered states of consciousness. The hypothesis is that it has an entropic effect, that it first disintegrates some of the networks that are altered in depression and later lets them connect in a more healthy way. So psychedelics may dismantle the cerebral activity patterns found in mental disorders, not only depression, but post-traumatic stress disorder and addiction so far. This is the same thing for psilocybin when compared to placebo. The networks that reconnect after its administration is remarkable. Also, returning to the inflammatory process of depression, they seem to work by having an anti-inflammatory effect. So we basically cover most of the things that are wrong in depression. Now, to finalize the talk, are we ready? Are we ready to use them as a regular treatment? I think we might be ready for continuing its use in research. I don't think we are yet ready to use them off-label or in our regular practice. I think we need more rigorous studies to know, can we maintain treatment with ketamine? Can we use chronic doses, repeated doses of regular psychedelics? Do we need to continue treatment as usual, even if it doesn't work in the beginning? Are there biomarkers for response or non-response? And we need to know a lot more about its mechanisms of action, and we also need to develop international consensus on when and when not to use psychedelics. This is similar to both ketamine and regular psychedelics, and one of the main concerns is its increasing off-label use, specifically in the United States. This affects the data that we found, that we have in the major international databases, and therefore may report less side effects and may report a higher antidepressant effect. So this is basically where I am in order to have some more questions and answers, and I thank you for your invitation and for your assistance.
Thanks, Rodrigo. And
Thanks.
there was a question here first, or? Yeah.
Sure.
Thank you so much. I was just curious about the dose in the ketamine study. Is it a high dose of ketamine?
Okay. It's a conventional dose for ketamine. It's a sub-anesthetic dose, which means that patients are not anesthetized. Patients received a 0.5 milligram per kilogram dose. This has been replicated in most clinical studies. It doesn't induce anesthesia. It doesn't induce patients to fall asleep, which allows us to guide them through the dissociative effects. Some people do, some people don't guide the patients, but only comfort them through these effects. But this is the dose used. It's a very low dose. It's a safer dose. It's a dose that can be guided by psychiatrists or mental health professionals and not necessarily anesthesiologists, which allows us to direct the properties into being antidepressant.
Yeah.
Hi.
Hi. Thank you for a nice talk. My name is Oscar. I'm wondering, when we talk about research in serotonergic psychedelics, psilocybin, or adaptogens, MDMA, the clinical trials focus a lot on the combination of the drug with psychotherapy. But when we talk about ketamine, it's usually just the drug. Why do you think that is? And do you think it would be interesting to do a study with ketamine with psychotherapy?
One of the differences is that ketamine has a 15 to 20-minute effect on the patient. This does not allow us to have psychotherapy sessions that may induce changes. Adverse effects and the effects fade over the next 30 minutes of giving ketamine. So that's one of the major limitations for using psychotherapy. So far, ketamine's effects have been focused on biological markers. This is also one of the limitations, but psychotherapy, after inducing these changes, might allow the BDNF to act in some areas, and this is there are some ongoing trials that explore this. The difference between regular psychedelics is that they have a longer time frame in which you can induce changes by psychotherapy. They have 2 hours up to 8 hours when talking about psilocybin or MDMA. This allows you to guide a patient through psychotherapy. This is also a necessity because most depressed patients do not have an earlier experience with psychedelics. So you have to first give a low dose in order for them to familiarize with the effects, also guided by psychotherapy. But I think the major difference is the time frame that you have for psychotherapy.
Can I reply to that?
Sure.
Because wouldn't it just be possible to do repeated doses with nasal sprays, for example? That would be one thing. Another, why do you think it is that we've been looking so much for biomarkers, like biological correlates with ketamine, and with different psychedelics been looking more of like the psychological aspect? My own answer to that would be, well, ketamine has always been in the pipeline. We've already had that as a drug.
To answer the second question, also psychological markers have been explored in ketamine, specifically some personality traits that have been found to predict a worse response or non-response at all. Borderline patients, dependent patients, or at least with some traits, do not respond as well to ketamine. It needs to be explored and the reasons why. And what was your first question again?
Sorry?
What was your first question again?
Well, I think you answered the first question.
Oh, okay.
Yes. Oh yeah. Couldn't you prolong the effect of ketamine by
giving repeated doses? We don't know if it's safe. We don't know if it's safe. We don't know how often we can give it in order to lower the risk of misuse potential addiction, or if chronic administration might be have a reverse effect. We know that when used as a recreational drug in major doses, in repeated doses, it increases the glutamate burst to a level in which it is excitotoxic, and therefore has basically the inverse effect that we try to find. So we don't know how often to give it yet.
More questions?
Thank you so much. That was a fantastic talk, really good. I run a clinic, a ketamine clinic in the U.S. as well as Norway, my comment is, your thought that this is sort of not ready for clinical use outside of research is, one that's shared by most people in academic psychiatry, like the consensus statement of the American Psychiatric Association. But the question is, in the setting of such poor current standard therapy that leaves so many people untreated, and because of the high morbidity and mortality of treatment-resistant depression, how can you say that it's better to not do something than to use a treatment that we know is effective? And there's an opportunity cost to not treating people. And over the last number of years, I've seen countless people's lives saved by this treatment. And although there's still so many more questions to be answered, it's been 2 decades since the initial randomized controlled trial, and there's a lot of experience, and there's a lot of clinical experience. There's tens of thousands of people that have been treated in clinics using off-label ketamine. So I guess that's, my question is, comment on that opportunity cost.
Sure.
I agree that there's questions to be answered, but what about not doing anything?
Okay.
Which is the current
Yeah.
standard. Good.
So there are 2 stances to this. One is the most Australian stance ever, which is to be basically too cautious about its use. And the other stance is the one that you are commenting on, is why are we limiting its use to patients that can benefit from the therapy? I also run an off-label clinic in Mexico. I've also had a great experience with using it. The main difference is that, or the main recommendation is to report this to the national databases. If the clinic is working that way, I do think that it might be used. It has also received a breakthrough drug stance, and if some standards and some consensus is reached, I do think that patients may be benefited today. But basically, the main recommendation would be to report the adverse effects, the response rates, and your protocol. How often do you use it, if you use repeated doses, and so. So the 2 stances are complementary, but I would just recommend to be cautious about it.
And, sorry, if I could just real quick follow up on in terms of the safety, concerns about side effects. So that the data with substance use disorders, with people abusing ketamine, those people are taking it every day, massive doses over long periods of time.
True.
And I would just comment that the same thing, we need to compare the risks and benefits of every medication that we use, but also to the risks and benefits of not treating, in that, suicide is a risk,
Right.
that we need to compare that
So
to bladder dysfunction and
Yeah. So there are 2 indications for ketamine that will be approved. The first one is treatment resistance, and the second one, as you mentioned, is suicidal ideation. As you mentioned, the adverse effects and the misuse potential has only been seen in patients that use it as a recreational drug, which means they use it more often and in much higher doses. So it's not a limitant.
How high are the recreational
at least 10 times, if not 100 times more than ketamine as we use it in the setting. So I think the dangers are latent, but I think the dangers are also overestimated.
All right, thank you for a very nice talk. My name is Samuel. I'm interested about these shared mechanisms between ketamine and psilocybin. So you were talking about the increase of glutamate basically as a kind of a primary mechanism leading to the subsequent changes in the intracellular cascades. Right. But what is actually the evidence of these particular glutamate changes in regards to psilocybin? And how would you, in the case of either psilocybin or ketamine, explain that how this, let's say, glutamate-induced BDNF expression is then driving these changes? Because, I mean, BDNF is a neurotrophic factor. It's driving the change of neural networks, but these effects seem to be happening almost immediately. So how can it explain both the acute and the sustained effects, in your mind?
So the acute effect is explained. I mean, this is only one of the explanations of its effects, of its mechanism of action. But the acute effect is explained by its immediate release in BDNF already stored vesicles. So this allows it to have an immediate effect, and the sustained effect is probably explained by how this cascades promote expression, and this takes time. So if you have both mechanisms, it allows for a rapid response, it allows for a prolonged response. Preclinical models, specifically animal models, show that this acute effect not only can be shown through molecular mechanisms, but also reflect, if you sacrifice the animal within the first week, you find increased volumes in the hippocampus and in the prefrontal cortex, which is one of the findings also in humans. So they do have these mechanisms, immediate mechanisms, and more prolonged mechanisms that might explain both properties.
So just to clarify that there is evidence from, let's say, microdialysis studies in animals that there's increased glutamate, and there's also evidence in human trials in imaging showing this.
Exactly.
Okay, time for 2 more questions, and then I'm sure you can find Rodrigo afterwards.
Yeah, hi. Thank you for your presentation. Just a quick question about, if I understood your presentation correctly, you used the participants were already on classical antidepressants.
Yes.
What would you say? Is that a way to go? You use ketamine as an added treatment, or what does the research say? Should you use ketamine only, or should you use that in combination with other drugs?
Our evidence shows that when using both kinds of drugs, it prolongs the response up to 3 months. So that is one benefit that might be added with conventional antidepressants. And also, in the next 1 to 2 years, ketamine will be found in the market. As most of you know, Janssen has been promoting the intranasal use. And the indication is to continue treatment as usual. But there's still a lot of evidence that needs to be collected.
Hi, I'm based out of New York, where I'm doing psilocybin work, and I haven't had any opportunities to work yet with ketamine, but I do think that there are political reasons more than anything why it hasn't been conceptualized as a psychedelic so much there, and the NIMH has funded a lot of the research, and they have very little interest at this point in studying psychedelics, and it seems that that's affected the way that it is both studied, as the first question addressed, and used in clinical practice, even off-label in clinics. But I'm also wondering if the fact that it hasn't been seen as a psychedelic, which I think has affected the extent to which set and setting are taken seriously in providing it, affects the longevity of the response, and whether, in your experience as both patient and provider, you think that perhaps thinking about set and setting might help people to make better use of what short time there is during that experience in a way that might increase the duration of the response.
I do believe that patients might benefit from the subjective experience. In my experience, Mexico is a very Catholic country. So some patients have had some spiritual revelations and experiences even throughout the 20 minutes that this effects last. That they find to benefit from that. I do believe also the set and setting is something to be considered. Patients are encouraged to close their eyes or use the bandage to cover their eyes. Patients are also, we recommend that either they bring some comforting music that they use, or we provide some comforting music. If that has a result in their subjective experience or result in their response is yet to be proven, but at least it has a very comfortable effect during the application.
Okay, thank you.
Thank you.
And on that set and setting, I see we have Mendel Kalin here, who's also talking about this later. So yeah,
Exactly.
we can come back to that. And yeah, warm applause to Rodrigo.
Thank you. Thank you.
And now we'll have refreshments. We'll find it outside. And back inside here, 11:20, we'll have Deborah